Hello everybody. Welcome back to Medicos. In the last video we have talked about the first disorder related with nutritional deficiency that leads to underproduction anemia, which is iron deficiency anemia. The second disorder related with nutritional deficiency is anemia of vitamin B12 deficiency. Vitamin B12 is a complex organometallic compound also known as cobalamin. Under normal circumstances humans are totally dependent on dietary vitamin B12. Ingested B12 can exist in two forms, either free or bound to dietary proteins. If it is free, the B12 binds to proteins known as R-binders or haptocorins, also known as transcobalamin 1, which are secreted by the salivary glands and the gastric mucosa, in either the saliva or the stomach. If the ingested B12 is bound to proteins, it must be released from the proteins by the action of digestive proteases both in the stomach and small intestine. Once the B12 is released from its bound protein, it will bind to the haptocorins. In the small intestine, the pancreatic proteases digest the haptocorins, and the released B12 then binds to intrinsic factor, a glycoprotein secreted by the parietal cells of the stomach when food enters the stomach. The intrinsic factor B12 complex attaches to specific receptors in the terminal segment of the small intestine known as the ileum. After the complex is internalized, the B12 within the enterocyte complexes with transcobalamin 2 and then is released into circulation. So absorption of vitamin B12 requires intrinsic factor, which is secreted by the parietal cells of the fundic mucosa. On the other hand, some intestinal bacteria need vitamin B12 for growth and may prevent its absorption by competing for it with intestinal cells. Intestinal bacterial overgrowth is associated with intestinal strictures, diverticula and blind loops. Vitamin B12 absorption therefore depends on normal gastric secretion of intrinsic factor, intestinal mucosa in the distal ileum and intestinal bacterial flora. Only two reactions in humans are known to require vitamin B12. In the first one, methylcobalamin serves as an essential cofactor in the conversion of homocysteine to methionine by methionine synthase. The second one is in the isomerization of methylmalonyl-CoA that is produced during the degradation of some amino acids, and fatty acids with odd numbers of carbon atoms. When we come to the pathogenesis it causes impaired DNA synthesis, specifically the S phase, which involves all bone marrow precursors and not just red blood cells, leading to anemia, thrombocytopenia, and leukopenia, generally known as pancytopenia. The impairment of DNA synthesis slows nuclear maturation, but not cytoplasmic maturation, so cells have nuclear cytoplasmic desynchrony. This results in ineffective erythropoiesis in which patients have an adequate number of red blood cell precursors. But many cells undergo apoptosis in bone marrow because of impaired nuclear maturation. It also causes neurological deficits, like peripheral neuropathy and spinal cord pathology known as subacute combined degeneration, involving posterior and lateral columns of the spinal cord. We will talk about it later. But this neurologic deficiencies are not seen in folate deficiency. It is important to remember that vitamin B12 is required for the regeneration of tetrahydrofolate. So lack of folate is the proximate cause of anemia in vitamin B12 deficiency. This means in vitamin B12 deficiency, administering folate will correct the anemia, however, it will not treat or prevent or even may actually worsen the neurologic deficiency. Administering folate bypasses the need for vitamin B12 in the production of red blood cells as there is no need to regenerate tetrahydrofolate if it is constantly being supplied. And also vitamin B12 deficiency causes elevated levels of methylmalonic acid and homocysteine. Elevated homocysteine levels have been linked to cardiovascular and neurologic disease. When we come to the causes of vitamin B12 deficiency, it might be due to one of these reasons. Pernicious anemia, which is the most common cause. Rarely dietary, which can occur in strict vegetarians. Gastrectomy, as it can decrease intrinsic factor production which is required for vitamin B12 absorption. and it is produced by parietal cells of the stomach. Ileal disease like Crohn's disease or resection can also cause vitamin B12 deficiency due to impaired resorption. And Diphyllobothrium latum or giant fish tapeworm can cause the deficiency too. The clinical manifestations of vitamin B12 deficiency vary with the severity of the anemia. As such, we cannot specifically determine that a patient has B12 deficiency only from the symptoms of anemia. But the general symptoms includes maturational defects, not just limited to red blood cells, but to all cells that are growing rapidly. Therefore, symptoms of the condition are related to pancytopenia, loss of all forms of bone marrow cells, and to the loss of intestinal cells, causing diarrhea and malabsorption and abdominal pain. Subacute combined degeneration, which is damage of the dorsal columns of the spinal cord which is highly myelinated tract, causing bilateral loss of proprioception or position sense, and damage of the corticospinal tracts of the spinal cord, causing spastic paresis. It may also involve almost any level of the neurologic system causing psychiatric, autonomic, motor, cranial nerve, and sexual dysfunction. And the patient may become somnolent or may become extremely irritable, which is also known as megaloblastic madness. This is because of increased plasma and urine levels of methylmalonic acid. Interruption of this reaction and the consequent buildup of methylmalonate and propionate, a precursor that could lead to the formation and incorporation of abnormal fatty acids into neuronal lipids or myelin sheath. It has been suggested that this biochemical abnormality predisposes to myelin breakdown and thereby produces the neurologic complications of vitamin B12 deficiency. Diagnosis: anemia with macrocytosis with neurological problem, although smaller number of patients may have the neurologic deficits alone. The WBCs have hypersegmented neutrophils with a mean lobe count greater than 4. RBC characterized by macroovulocytes. Although macrocytosis can occur with hemolysis, liver disease, and myelodysplasia, these disorders give round macrocytes unlike B12 and folate deficiency that produce oval macrocytes. An elevated methylmalonic acid level occurs with B12 deficiency and is useful if the B12 level is equivocal. When we see one of the most common causes of vitamin B12 deficiency, we find pernicious anemia. Pernicious anemia is a specific form of megaloblastic anemia caused by an autoimmune gastritis that impairs the production of intrinsic factor, which is required for vitamin B12 uptake from the gut. Histologically, there is a chronic atrophic gastritis marked by a loss of parietal cells. The pathogenesis of pernicious anemia includes autoimmune condition due to antibodies against parietal cells, blocking antibodies that prevent binding of vitamin B12 to intrinsic factor, or antibodies against the vitamin B12 intrinsic factor complex. Any of these three antibodies prevents the absorption of vitamin B12. Pernicious anemia is insidious in onset, and the anemia is often quite severe by the time it comes to medical attention. Unless halted by therapy, the course is progressive. The diagnosis is based on a moderate to severe megaloblastic anemia, leukopenia with hypersegmented granulocytes, low serum vitamin B12, and elevated serum levels of homocysteine and methylmalonic acid. People with atrophy and metaplasia of the gastric mucosa associated with pernicious anemia have an increased risk of gastric carcinoma. When we see the third disorder related with nutritional deficiency, there is anemia of folate deficiency. Folates are synthesized in bacteria and higher plants and ingested in green leafy vegetables, fruits, and legumes in our diet. The vitamin was named for its presence in green leafy vegetables or foliage. A deficiency of folic acid results in a megaloblastic anemia having the same pathologic features as that caused by vitamin B12 deficiency. Suppressed synthesis of DNA, the common denominator of folic acid and vitamin B12 deficiency, is the immediate cause of megaloblastosis. The three major causes of folic acid deficiency are decreased intake, increased requirements, and impaired utilization. Decreased intake can result from either a nutritionally inadequate diet or impairment of intestinal absorption. Inadequate dietary intakes are almost invariably associated with grossly deficient diets. Such dietary inadequacies are most frequently encountered in chronic alcoholics. Consumption of high amounts of alcohol may have a direct effect on the folate absorption, due to inhibition of the enzyme intestinal conjugase. The other mechanisms of folate deficiency in alcoholics with cirrhosis might also be due to trapping of folate within the liver, excessive urinary loss, and disordered folate metabolism. Malabsorption syndromes, such as SPRU, can lead to inadequate absorption of this nutrient, as can diffuse infiltrative diseases of the small intestine like lymphoma. In addition, certain drugs, particularly the anticonvulsant phenytoin and oral contraceptives, interfere with absorption. Despite normal intake of folic acid, a relative deficiency can be encountered when requirements are increased. Conditions in which this is seen include pregnancy, infancy, derangements associated with hyperactive hematopoiesis or hemolytic anemias, and disseminated cancer. Skin loss in diseases like eczema, or increased loss from dialysis can also cause it. In all these circumstances the demands of increased DNA synthesis render normal intake inadequate. When we see the diagnosis, the hematologic presentation of folic acid deficiency is identical to B12 deficiency. The diagnosis is based on a low red blood cell, and low folic acid level. To summarize, macrocytosis or megaloblastic anemia is caused by vitamin B12 or folate deficiency. The anemia caused by both vitamin deficiency is the same, since suppressed DNA synthesis is the common denominator for both. The other important point to remember is although the anemia part of the clinical manifestation is the same for both, vitamin B12 has additional neurological manifestation which is known as subacute combined degeneration, and other neurological manifestation too. So before treating megaloblastic anemia with folate it is important to rule out vitamin B12 deficiency, because administering folate will correct the anemia, however, it will not treat or even may actually worsen the neurologic deficiency. The causes of vitamin B12 deficiency might be pernicious anemia which is the commonest one. Dietary, gastrectomy, ileal disease, fish tapeworm. While the major cause of folic acid deficiency are decreased intake, increased requirements, and impaired utilization. Thanks for watching. If you like this video please like and subscribe for more. You can also check out my other video about the different types of anemia.